Hi, I'm Dr. Jason Goodchild with Premier, and joining me again is Dr. Mark Donaldson, pharmacologist from Whitefish, Montana. And today I thought perhaps we would have a little discussion about an area of interest for both of us. In fact, we recently co-authored a publication about an especially concerning topic for dentistry, and that is chlorhexidine allergy. Now, when Mark and I bring this up to a group of people, a lot of people look at us like, is that really a thing? But in fact, it really is a thing. And there's a lot to talk about, especially with the idea that we are exposing patients to chlorhexidine from a lot of the things we do in the dental office. And so I really wanted to bring Mark back in to talk a little bit about, how does chlorhexidine work? When did chlorhexidine come to market? And then talk specifically about the risk of allergy. So welcome again, Dr. Donaldson.
Yeah, thanks for having me.
So first question, can you tell me a little bit about the history of chlorhexidine? And it's ubiquitous in the dental office. It feels like we do chlorhexidine rinses all the time. We use it as a part of restorative dentistry. But how long has it really been around?
Yeah, well, I mean, it's actually been around for a long time. It was first synthesized back in the 1940s. It was a group called Imperial Chemical out of the United Kingdom who used it. And they had initially promoted it as a topical antiseptic. And it was finally in 1969, a company named Loe, L-O-E, that introduced it as a mouth rinse. And what's interesting is that they introduced it as a mouth rinse at a percentage of 0.2%. And that's kind of important because that's a higher percentage than we typically see in, let's say, Paradex or some of the generic mouth rinses that you see here. The reason it's important is because while they had originally, from the late 60s, early 70s, been using this as an oral rinse to help prevent the development of plaque formation and gingivitis, and there was never any adverse effects associated with it. The one thing that they did see was tooth staining. And so when it came across to this side of the pond, Procter & Gamble picked it up and patented it in 1986 as Paradex. And of course, rather than that higher 0.2%, they've been marketing and packaging it as 0.12%. What that has resulted in is essentially getting all the good effects without the bad effects. And it was actually the very first oral healthcare product to receive the American Dental Association Council seal of acceptance for control of plaque and gingivitis. So it's a very important chemical, very important mouth rinse. It's actually also on the World Health Organization list of essential medications. So, nothing but really good news round about the history. But I think what we're going to get into discussing is, similar to the latex analogy with almost the overusage or ubiquitousness of this particular medication. With these multiple exposures from different areas, we are starting to see almost an induction of allergic type reactions, all the way from level 1 to level 4. Level 4 perhaps being, level 1 being perhaps the most serious as an anaphylactoid reaction resulting in death.
Yeah. You mentioned the tooth staining, and of course, I think we're all sort of ingrained to think about mentioning that to patients when we prescribe it, the idea of potential staining and also potential taste disturbances. But why is chlorhexidine become so popular? On the perio side, you mentioned inhibition of plaque, help with gingivitis. Why is it? How does it work?
Well, in truth, it is a broad spectrum antibiotic or antimicrobial, and so it does cause bacterial cell lysis. So the opening of the cell wall. Typically, the cell wall of bacteria, whether that's gram-negative or gram-positive, does contain some charged molecules. And by attaching to those charged molecules, this sort of cationic aggregation, it does cause breakdown of the cell wall, exposing the internal workings of the microbe, again, both gram-positive and gram-negative, to the outside, resulting in cell lysis and programmed cell death. It does have some antifungal and some antiviral properties, which obviously very topical given our current pandemic, which I'm sure we'll get to. But primarily it's because of that antibacterial or antiseptic effect. It's been shown to be not only effective in dentistry, of course, but there's one very unique property, and that's called its substantivity. Substantivity is the ability of this particular molecule to sort of hang around much longer than beyond the point at which it's applied. So anytime we put something in the mouth, we're concerned that we're going to have to reapply several times because it's going to get washed away with saliva, swallowing, mastication, and eating. But actually, chlorhexidine hangs around the mouth due to the substantivity characteristic for quite a long time. When we use it as a perioperative antiseptic, so on the skin prior to general surgery, it actually will hang around on the skin externally for 24, 48 hours. So a good broad spectrum antibiotic with significant substantivity. And I think it's been both of those, plus the fact in general, it really doesn't have a lot of side effects or adverse reactions other than the few that you mentioned from a dental perspective. In fact, if you take a look at current guidelines, looking at the old FDA scaling for risk in pregnancy, it was always characterized as pregnancy risk category B as in boy. So very, very safe. There is limited information as to whether or not it could be transferred into breast milk, but there aren't any contraindications for it in the breastfeeding mother either. So in general, very, very safe.
Yeah. And I think that has led to the popularity in the dental office. It kind of feels like for people who have bleeding gums, gingivitis, as an adjunct to periotherapy, we're writing prescriptions for chlorhexidine. And because of that substantivity, the proper prescription would be rinsed twice a day because it hangs around in the mouth for a long period of time. But allergy to chlorhexidine is something that I just don't think that a lot of dentists appreciate. And I know that through our research, we were able to identify some troubling information. The idea that the FDA and the counterpart in, I believe, the UK have issued several warnings about the incidence of allergy and potentially, as you mentioned, type 1, which would be immediate type allergy and anaphylaxis. And so how long has this been, have we been documenting this for lots of time, or is this a new thing with chlorhexidine?
Yeah, great question. I will tell you that, the very first documented allergic type reaction to chlorhexidine was actually back in 1965. So even before Paradex was available here in the United States. So we were very aware at a very sort of early stage in its development that it could have the propensity towards allergenicity. The first anaphylactic reaction, though, is you actually do have to fast forward to 1984. 1984 was the very first time that we recognized a patient had that true type 1 allergic IgE-mediated anaphylactoid reaction to chlorhexidine. And of course, that's the point really at which we become much more attuned to the ubiquitous nature of this. As you said, certainly in the dental realm, chlorhexidine is in a number of different preparations. Their exposure not only to patients, but also to team members. And I think what really kind of inspired you and I to take a look at this more closely, and not just its history, but its allergenic potential, was because for the very first time in 2000, I believe it was 2017, not patients exposed to chlorhexidine, but actually a dentist, an oral healthcare provider who was exposed to chlorhexidine in the workplace. It was aerosolized in the air, and he had an anaphylactoid reaction to it and actually died. So you go from patients being exposed and having perhaps a topical sort of slight allergic type reaction to patients being exposed and dying from an anaphylactoid reaction. And now you have oral healthcare workers, given their environmental exposure, being at risk for anaphylaxis and even death. I'm just not sure that everybody's as well aware as to how dangerous this drug can be in certain situations.
Yeah. And I was just going to mention, actually, I'm thinking that case you're talking about, it was either 2007 or 17 or 2018. And from what I remember, he put chlorhexidine on a cloth and was cleaning a hard surface, and that helped to aerosolize the chlorhexidine, and he had an anaphylactic reaction. I do believe that he lived, but two other patients died, and that was what sparked these warnings from the FDA. And as a PSA, both of those patients died of anaphylaxis following a chlorhexidine exposure, and in both cases, they were exposed because the dentist irrigated an extraction socket with chlorhexidine. So, as again, a PSA, whether you have seen or believe in chlorhexidine allergy, which I hope that everybody does, given the seriousness of it, the take home should be really, we should not be irrigating open wounds, especially extraction sockets with chlorhexidine.
Yeah.
The next question I wanted to ask you, though, is around um, how does chlorhexidine allergy present following, let's call it an oral exposure? We prescribe the Paradex, the patient calls us the next day and they're potentially having a problem. How do they usually present? Do you know what their symptoms could look like?
Well, I mean, it is a broad spectrum, as you're well aware. I mean, it can be general irritation in the oral cavity, where somebody feels almost that hives or urticaria, kind of an itching, that type of not usually noted so much with swelling in some patients, but again, given the sort of constellation of response, they could have some swelling, but definitely that sort of itchiness feeling, all the way to people that they just feel that they have a difficulty catching their breath, and that shortness of breath, or that thought that it's just a little bit difficult to breathe after I do this, again, could be related to airway edema. But it gives you a high index of suspicion. You're a clinician that uses this all the time. I'm sure patients report to you kind of their sensation that they may experience when they rinse with chlorhexidine.
Yeah, and some of the most troubling ones that I've been reading about, and we included in our publication, were that not only did they have reports of oral irritation, things just weren't right in their mouth, and that was kind of an easy differential to kind of point towards chlorhexidine. But there were some reports of chlorhexidine allergy, and these are the ones that really concern me, that appear outside the mouth, where patients would then report on the back of my neck, on the back of my arms, I'm feeling itchiness and rash. And from the reports that I've been reading, unfortunately, dentists dismissed those as, that couldn't be from chlorhexidine. The exposure's in your mouth, and why are you getting a rash on the back of your arms or the back of your neck? But in reality, those were actual cases of chlorhexidine allergy. And so I think anytime we prescribe a medication and then immediately following or soon after patients are reporting some of these things, we have to put all things on the table. Could it be what we prescribed? And just because this reaction doesn't necessarily present in the mouth doesn't mean we shouldn't discount the possibility of chlorhexidine allergy.
Mhm.
The last thing I wanted to talk about is a little more topical. In the midst of the COVID pandemic, and dentists are so used to using and accustomed to using chlorhexidine oral rinse. Is chlorhexidine oral rinse an oral rinse that can actually kill the COVID virus? Is that something that we should be recommending as a pre-procedural rinse for our dental patients?
Yeah, so actually that data is very clear, and the short answer is no. So while chlorhexidine may have some antiviral properties that we talked about earlier, against COVID-19, it truly is ineffective. And in fact, the amount or concentration of chlorhexidine that would have to be considered an antiviral dose, far exceeds what you would be able to achieve, and would even want to expose a patient to. The alternate, and I know that this is supported by the American Dental Association as well as the CDC, is of course hydrogen peroxide. And I think everybody feels very comfortable that a 1% hydrogen peroxide sort of swish and spit approach for that pre-procedure rinse, as you spoke about, is really the way to go. Now, if you had patients at high risk also, or those that wanted to almost prophylax at home, or they happen to live with a family member who was a high risk individual for exposure to COVID, they could at home make their own solution. Hydrogen peroxide, typically available as commercially as a 3% solution, so they would want to make sure that they dilute that at least 2 to 1 or even 3 to 1. And again, that same idea of rinsing and spitting. I know that some people had even tried, sort of soaking their toothbrush overnight in a hydrogen peroxide 1% solution, perhaps denture wearers too, if that's something they wanted to look at. But for right now, we definitely do not want to be recommending chlorhexidine as a topical rinse prior to any type of oral procedure, with the thought that perhaps it could prevent COVID. That's just not
Yeah.
borne out.
Yeah, that's what I'm hearing too, in that to reduce the viral load in saliva before we potentially have to do dental work, and maybe even especially before we could do any dental work that could potentially cause an aerosolization, that hydrogen peroxide rinse is really what is being recommended.
Yeah.
All right. Well, hey, Dr. Mark, I appreciate the time today. And, I think that we'll check back in with you soon.
Absolutely. Sounds good.
Thanks,
Take
man.
care out there in the wild.
All right. Sounds good. Talk to you soon.
Okay. Bye-bye.
All right. Really good.